Welcome to Sims MedPrep. Dr. Kamran Khaja is here. We are going to start endocrinology second lecture. So we have discussed the first lecture. So this is a endo series lecture number 02. Thank you so much. So we are going to discuss the anti-diuretic hormone. In our previous lecture, we have discussed the anatomy and embryology of thyroid. We have discussed the anatomy of the adrenal glands. We have discussed the different pituitary hormones. We have discussed the regulation of pituitary hormone, and we have discussed the detail about the growth hormone. In this second lecture, we will discuss first of all the antidiuretic hormone. So antidiuretic hormone is also called vasopressin. So we have discussed in our previous physiology of pituitary, that is, these hormones is produced in the hypothalamus, in supraoptic and paraventricular nuclei, and they are stored in posterior pituitary. So super high yield MCQs number 1 here. So where is production site of antidiuretic and the other hormone? That is oxytocin. So these are produced in supraoptic and paraventricular nuclei, and they are secreted by the posterior pituitary. And a protein who carry this hormones from hypothalamus to posterior pituitary, the name of that protein is neurophysin. Neurophysin protein. Next, we will discuss about the function. What is the function of antidiuretic? It regulates the blood pressure via V1 receptor, and it regulates serum osmolality via the V2 receptor. Okay, so vasopressin, which is antidiuretic, has V1, V2, V3. Okay, so also there is a V3, but it's not very important. We will discuss about V1 and V2. V1 is present on the blood vessels, so it causes vasoconstriction. Vasoconstriction on the vessels. Okay, and serum osmolality, which is V2. So V2 is acting on the kidney. It's acting on the kidney, which is the distal collecting ducts. So that collecting ducts will be leading to increase water reabsorption. So what happens? Antidiuretic vasopressin attaches in the distal collecting ducts, and it causes the upregulation of aquaporin 2 channels. Very high yield important MCQs here. So what is upregulation of aquaporin channels? What are these channels? These channels are present in the collecting ducts. Okay, when these aquaporin channels are inserted into the collecting duct cells, which is a specifically principal cells. So when aquaporin inserted in the membrane, so they capture water from the ducts. So they causes the reabsorption of the water. So that is very important. So first chain of event is that vasopressin, it comes on, this is, I am making a principal cell. This is a principal cell on, and this is a tubules. This is a collecting duct. This is collecting duct side, and this is the blood vessel side. Okay, this is the vessel side. So there are aquaporin channels which are present at this position. Okay, aquaporin channels are present here. So vasopressin will act on this side. This is the side of vasopressin. Okay, so there is the vasopressin ADHV2 receptor are here. So ADH will come and attach at this site, which is near to the vessel. So this causes intracellularly upregulation, and there is normally the aquaporin channel are present here at this position. Now, when there is V2 receptor activation, so what happens? These aquaporin channel will go to the membrane side at this position, and now the water particle H2O will be reabsorbed at this. So this is a mechanism of antidiuretic. Is that clear? So we have discussed the how it acts. So what is the osmolality? Osmolality is determined by the sodium ions, most likely. So you should know that when we talk about osmolality word, osmolality, so it's remember it is due to sodium ions. Okay, any ions, but most likely sodium ions. So primarily this antidiuretic hormone function is serum osmolality regulation. Okay, serum osmolality regulation. So osmolality is determined by the sodium ions most likely, and that sodium is the determined osmolality. So ADH is regulated by the serum osmolality. So first of all, you must understand the osmolality concept. Here is a glass number 1 and here is a glass number 2. Okay, so I put here a 1 gram salt. Okay, and I put here a 2 gram salt. Okay, salt means sodium chloride. So can you tell me which has more osmolality? Okay, same both have 200 ml capacity. So glass number 1 and glass number 2, which will have more osmolality? Glass number 1 has only 1 gram salt and glass number 2 has 2 gram salt. So osmolality will be high in glass number 2. Glass number 2. Okay. I have told you the osmolality is determined by sodium ions. When there is a more salt on this glass 2, so there is more osmolality. Okay. Water is same. Solute is more in glass. So solute is determining osmolality. Remember this. So when solute is high, when increased solute, it increases the osmolality. But there is another way that increases osmolality, and that is relative. That is decreasing the water increases the osmolality. Why? Why? Because when we remove the water, the relative ion concentration increases. So that increases osmolality. Now take this same example. Same example. Now what will do? I will remove 50 ml water. Now I will remove the 50 ml water. Okay. This is glass number 1, which is having a 1 gram. It is glass number 2, which is having a 2 gram salt. Okay. Now I will remove like 100 ml water removed from glass 1. 100 ml water is removed from glass 1. Now the water layer is only at this level. Water is filled by only this. Okay. So this area is free. No water here. But it is filled totally. Water is filled in glass 2. This is a 200 ml complete. So now you can tell me which has more osmolality, glass number 1 or glass number 2. Glass number 1 has 1 gram salt, 1 gram is only 100 ml. 1 gram salt and 100 ml. Glass number 2 has 2 gram salt and 200 ml. Which has more osmolality? It is very interesting. Very interesting. Both have same. Okay, at 1 gram in 100 ml, 2 gram in 200 will be same. Now I will remove the 120 ml now. I will remove the 120 ml from this. Then this will be greater. Osmolality will be greater in this. So all I want to clear is that osmolality is determined by solute, and solute is most likely sodium ions. So whether there is increased concentration of solute or whether there is the decreased concentration of water. So if we decrease the water, it increases osmolality. So you should know this. So ADH regulation, it is determined by the serum osmolality. So now what happens? ADH decreases the serum osmolality. So make a concept by this picture. I have told you already. This is a principal cell. In this principal cell, on this side there is vessels that is causing the water reabsorption toward the plasma. And here are the aquaporin channels. And you should remember this picture. This is the tubules. This is tubules. So water is going via this aquaporin channels into this vessel. So ADH is causing this. So now this is a tubule which will make eventually a urine. Okay, it will make urine. And this is a plasma. At this level, this is a plasma. So we will determine the plasma osmolality changes after ADH, and we will check the urine osmolality changes after the ADH. Now we will increase the ADH. Yeah, normally ADH causes increased water shift from this tubular toward this vessel. So what will happen when water is decreased from the tubules? So what will be osmolality of urine? Please answer. When ADH is removing the water from the tubules, tubules mean urine. So what will be the urine osmolality? I have told you when we remove the water, it increases accident after that. So it is a normal, easy concept. Easy concept. So first of all, because water is coming, water is going from this tubule portion towards this vessel portion. So water is less in the tubule, mean less water mean relatively more ions, more solute. So more solute mean more osmolality. Okay, after ADH. So ADH causes the increased osmolality of water. This is a concept. Next. So now water is being added. So there is more water here in the plasma. So what will be when we add more water in a system? So the already present solute are same. Already present solute are same. So when we add more water in a system, that will causes a relatively decreased concentration of ions. Okay. Let's suppose there was a 4-liter fluid in our body, but ADH causes 4.5 liter. So more fluid, it means relatively ion concentration is the less. So it decreases the plasma osmolality. Is that clear? So we have discussed about the concept of osmolality. Now we will go for the regulation of the ADH. ADH is regulated by the osmolality hypovolemia. Remember all this. Okay. Plasma concentration, blood volume osmolality, blood volume osmolality. This is a regulation. Okay. Osmolality, hypovolemia, or indirectly, I can say the blood volume. Okay. It's determined. ADH is decreased in central diabetes insipidus and normal or increase in nephrogenic diabetes insipidus. So we'll study in our pathology section. Nephrogenic diabetes insipidus caused by mutation in V2 receptor. And desmopressin analog is the treatment of central and the nocturnal angiolysis. So we'll study in the pathology section. Okay, we should know this. And there is also a concept. There is also a concept that there is a V3 receptor. These are sometimes regarded as present in skin. Okay, they have importance in the regulation of most likely in the temperature mildly V3 receptors. Okay. Next, there is also a few more concepts about this antidiuretic hormone vasopressin. Vasopressin, interesting concept is that this is the procoagulant, pro-aggregation factor. So this is also a concept at a high doses. At high doses, it causes the coagulation. It is pro-aggregation molecule. So this is also a concept very interesting, but not written in book. You can memorize it. Vasopressin also has a pro-aggregation in high doses. And also ATH and vasopressin is increases, very important, vasopressin increases the factor 8. Okay, factor 8. So that's why which is a desmopressin, which is analog of the vasopressin, is used in the hemophilia A. Okay, hemophilia A. Why? Because hemophilia A is a factor 8 deficiency. So when it's increases a factor 8, so that's why it is used in the treatment of hemophilia A. So vasopressin increases factor 8. Is that clear? Okay. There is another concept about the growth hormone related, that is constitutional growth delay. So what is constitutional growth delay? Constitutional growth delay is usually a term that is a misnomer. It is not actually a growth delay, and there is no need to worry about. This is a temporary period of growth delay, which is between 6 months, 3 years of life. And the child presented with a short stature sometimes, and sometimes there are growth spurt are delayed, and the parents are parents are worried about that child is not having normal growth, uh, and the growth spurt is delayed and all the other problems. But very important point, you have to reassure the parents that in that eventually this child will attain normal height and normal growth spurt. So this is a temporary that starts from 6 months up to 3 years of age. Okay, so they will give you history like this. Okay, a child of the 1.5 year presented to the clinic, to growth clinic, and they have a short stature and there is a pubertal delay. But they will describe you, there will be normal birth and height, weight and height is normal, and what will be the next step? Reassurance. Okay, so there will be the answer will be reassurance. So there will be only short stature. Okay, they have a normal birth weight and height, no issue during the birth, and starts with 6 months to 3 year of age, and his growth velocity slows, and child drops the percentile on the growth curve. But around the 3 year of age, the child regains the normal growth velocity and follows the growth curve at 5th to 10th percentile. Okay. So normally when we define the short stature, it is the less than second percentile. Okay. Short stature is the term that is used, and there is in the growth chart, there is a growth chart. Actually, we monitor all the child's growth on growth chart. In growth chart, if there is less than second percentile height, that we say that is short stature. But after the 3 year of age, that child will attain greater than second percentile, like 5th to 6th, 7th, 8th, 10th percentile. So it will be normal. So this child will eventually this child will have a normal growth spurt and reach the normal adult height. So next, bone age radiograph show the bone age that is delayed as compared to the chronological age. Is that clear? Okay, going to the next. Prolactin. Prolactin, we will already discuss about this in our physiology section of pituitary gland, so we will quickly revise all of this. Prolactin is released by the anterior pituitary and strictly homologous to growth hormone, and that's the reason they both have the same action, same, almost same mechanism, okay, of action. Okay. They have a homologous. So next important is what is the function of this? Milk production in the breast and inhibits the ovulation in females and spermatogenesis. Why I have told you. Prolactin is inhibiting the gonadotropin releasing hormone. When there is inhibition of gonadotropin releasing hormone, it decreases the FSH, it decreases the LH. When it decreases the FSH, decreases the LH, so what will happen? It decreases the estradiol and it decreases progesterone. So you know that estradiol, progesterone is necessary for the ovulation. So it inhibits the ovulation, it inhibits spermatogenesis because these progesterone and activated dihydrotestosterone and activated estrogen, that is estradiol, are not produced. So that leads to the ovulation and spermatogenesis problem. Next, excessive amount of prolactin is associated with decreased libido. And what is mechanism? We have discussed about this via inhibition of the gonadotropin and inhibition of FSH and LH. FSH LH decreases the estradiol and the progesterone, and there is no activation of form of progesterone, so that's no dihydrotestosterone. There is decreased libido. Next, regulation. Prolactin secretion is from anterior pituitary. We have discussed this already, and inhibited by dopamine. We have discussed in detail. But here you should know the MCQs. Very important MCQs here is the this which of the following pathway is of the hypothalamus is controlling prolactin release, or which of the following pathway is inhibited by the dopamine? That is tubuloinfundibular pathway. This is very important. This is controlling the release of dopamine and the prolactin pathway. Very interesting. I have told you in my previous first lecture, the prolactin in turn inhibits its own secretion. Very interesting. Very important here. Prolactin is the only hormone. Dopamine or tubuloinfundibular pathway has one of the most characteristic feature that is not present in all of it. Okay, that is very super high yield MCQs. This is the only hormone in pituitary that is controlling its own inhibition. Its own inhibition. That is a chronically inhibitory. The nature has created a system that this prolactin is always inhibited, so that our system must go in a normal path. It is inhibited. This dopamine is always released, so that this prolactin must be in a regulation. So, okay, when there is more prolactin released, automatically it increases the dopamine synthesis and feedback system. So our nature has created a system that When there is more prolactin release, more dopamine will be. More dopamine will causes inhibition of this further release of prolactin. So the prolactin itself is tonically inhibiting its own release. Its own release is inhibited by the prolactin. So that is a regulation. Very interesting regulation to prevent the excessive prolactin. Super high yield question. Next, thyrotropin releasing hormone increases prolactin. We have discussed in the hypothyroidism. So we have discussed in previous lecture how the hypothyroid causes the prolactin and thyrotropin releasing. Okay, so next we will discuss about the dopamine agonists. Dopamine agonists are the bromocriptine and antagonists are the most medications. Dopamine agonists are bromocriptine capable in which there are other different we will study detail in the hyperprolactin. So dopamine agonist, most important is bromocriptine that inhibit prolactin secretion and used in the treatment of the prolactin. And dopamine antagonist, some of the medication like we give the antipsychotic medication, yes, like haloperidol, most commonly culprit drug that causes this. Okay, and most likely estrogen, oral contraceptive pills, and pregnancy stimulates prolactin secretions. Okay. Dopamine antagonist also metoclopramide. Metoclopramide is anti-emetic drug, anti-emetic, and it is also causing this side effect that is hyperprolactinemia. Okay. So, so we have discussed now what is agonist. Agonist is that molecule that is acting as the same function, same action, and boosting up the function of prolactin. The agonist is, for example, the dopamine agonist mean that compound that will acting as like the dopamine, like bromocriptine. And antagonist is that molecule that will inhibit the action of the dopamine. So some of the drugs that we discussed about the dopamine, these are antipsychotics and metoclopramide. And estrogens molecules like oral contraceptive pills and hyperestrogenic states like pregnancy is hyperestrogenic state. So also it stimulates the release of prolactin. Now we will discuss about this beautiful regulation pathway that is first start this hypothalamus. First, when there is a cry of the baby, and you see the baby, a mother who sees the baby, there will be a response in our hypercortex. This is a higher cortical center. Okay. So what will happen? It will causes the activation of the pathway. What pathway? What pathway? Inhibition of dopamine. When there is a cry of the baby, when the mother see the baby, what will happen? Dopamine will inhibit and prolactin will increase. Is that clear? Because whenever you see and mother see the child, there is when there is nipple stimulation, when there is chest wall injury, when there is some medications, they inhibit the dopamine. So most likely there is nipple stimulation, chest wall injury. Chest wall injury actually causes the ANS, autonomic nervous system. Okay, sudden blunt injury, chest wall injury is causing the inhibition of the autonomic system. Now, inhibitory will be diminished, so there will be no release of dopamine. No release of dopamine while this chest wall injury causes more release from the prolactin from injury. And some of the medications we have discussed dopamine antagonists. So these all inhibits the dopamine and increases the prolactin. And now we will discuss about other pathway that is hypothyroid. Hypothyroidism, either primary or secondary. They increases thyrotropin releasing hormone from the hypothalamus. Thyrotropin releasing hormone increases the not only thyroid stimulating hormone, but also it increases the prolactin. So thyrotropin basically increases thyroid stimulating hormone from interior production. But also thyrotropin releasing hormone increases the prolactin. Okay, so both hormones increase. So in this way, there is increased prolactin. So we are here. So this prolactin when increase is causing the milk production in mother. But adverse effects we have discussed it inhibits the gonadotropin releasing. When it inhibits gonadotropin releasing hormone, inhibit FSH, decrease release of FSH, decrease LH, and there will be no ovulation and no spermatogenesis. Okay. When there is pregnancy state, we have discussed pregnancy increases estrogen and this causes the more prolactin. Very interesting concept here is the renal failure. When there is a renal failure, It also increases the release of prolactin. Why? Because of reduced prolactin elimination. Prolactin is excreted by the kidney. So when there is a CKD, so there will be more. So there is a one of the major cause of, which is famous cause of the hyperprolactinemia. So in the step 2 exam question, this is usually comes in step 2 USMLE step 2 exam, they will ask about the medications and ask about the CKD, chronic renal failure, chronic kidney disease. It's also the cause of the hyperprolactinemia. So we have discussed about this regulation. Next, we will move to the thyroid hormones. Okay. Now we will discuss about the basics of, we have studied the embryology and anatomy of the thyroid hormone. Now we will discuss the physiology of the thyroid hormone. Thyroid hormone, first of all, you should understand the basic structure of the thyroid follicle cells. First of all, you should know the basic structure. Okay. You should know the follicle, thyroid follicle, there is a epithelial cells where there is a production of a hormone, that is thyroid follicular epithelial cells. And these thyroid follicular epithelial cells are associated with the blood, associated this area. This is the blood. Okay. And next you should know there is a lumen. That lumen is denoted by this area. This is the lumen. And last, which is peripheral tissue. Okay. Besides this blood area, this is the peripheral tissue. So you should know these. So first of all, start from thyroid follicular cell. And next is associated blood. And third is follicular lumen, and fourth is peripheral tissue. Where is the start of this production of thyroid? First, you should know the prerequisite molecules that are necessary for creation of T3, T4. That is iodine. Okay, so T3 is triiodothyronine and T4 is 4. T4 means 4 iodine. So first prerequisite is iodine. So where iodine will come? Iodine, of course, will come from blood. Is that clear? So now we will study the first of all step. What are the steps that creates T3 and T4? Okay, now we will discuss about thyroid produces triiodothyronine and thyroxine. This is the tetraiodothyronine. These are iodine containing hormones that control the body metabolic rate. Okay. Now we will discuss step by step in this system. Start from the blood. Yes. Iodine, which is shunted inside this thyroid follicular cells via a transporter protein. This transporter is iodine sodium transport. Okay. Iodine sodium transport. So one negative charge will go and one positive will go to to causing the neutral charge inside the cells. So when this iodine will go, it will be made in a second step. This is called oxidation. This was the first step, which is the entry of the iodine. And next step was the oxidation. Okay. Iodine, which was present in the negative charge, now it will be converted into iodide molecule, that is I2. This was the second step. Okay. Before going to the third step, we should know what is thyroglobulin. Thyroglobulin is the globulin protein, which you can think about. This is a protein, and protein is made inside the cell. Okay, there is a processing of protein. So the thyroglobulin will be produced inside cell, and that thyroglobulin is this. So it will be transferred into this follicular lumen. Now the iodide molecule and this thyroglobulin, with they will make a very characteristic combination, that is monoiodothyronine, diiodothyronine, and diiodothyronine. This is a different iodine molecule will be attaching this thyroglobulin, and this structure will be neat. This is step number 3. Okay. This is called organification. Thyroglobulin attaching with iodide molecule under influence of thyroid peroxidase. Thyroid peroxidase is enzyme that is called okay. Thyroid peroxidase. Next is coupling reaction. Very important reaction. Fourth concept is coupling. What is coupling? So we know that there is monoiodo and diiodo, but this is not active form of the thyroid. So there is active form is the T3 and T4. So there will be a coupling reaction. What coupling reaction? This MIT will combine with DIT and it will make the T3. And both DIT and DIT will combine and make T4. This is called couple reaction. Okay. Monoiodothyronine will combine with diiodothyronine and it will make triiodothyronine T3. Okay. The two molecule of diiodothyronine will combine and it will make the T4. This is called coupling reaction. Step number 4. Now we will go for step number 5. Step number 5 is the endocytosis of this protein structure. So this is a protein attaching with iodine coupled molecule. So it will go from follicular lumen inside follicular epithelial cell. Now, next. This is reaction number 5. This is number 5. Okay. 5 number, this is endocytosis. So this is now present inside this thyroid for epithelial cells. This is 5. Now we will discuss about next very important concept here. Deiodination. Deiodinase is an enzyme that causes D-mean removal. It removes iodine and removes the, and it creates the, recycles the thyroglobulin. Very important. And next, reaction number 6. This is a deiodinase. Okay. So what will happen? The MIT and DIT, which are actually unprocessed, which is not necessary, which are unprocessed. So that will lead to the further the thyroglobulin that is associated with MIT and DIT. This is detached and that thyroglobulin will go into the cycle. And very important 7th point, super high yield point, is the protease enzyme. That protease causes this T3 and T4 to go into this blood. That is our super high yield concept 7 point. That is the now T3 and T4 is present in our circulation, in our blood, and ready to act on the organs. Is that clear? So at this 7 point, there is a T4 greater than T3. So normally there is more production of T4, and further T4 is converted into T3 in the periphery under influence of the enzyme that is 5-deiodinase. Super high yield 5-deiodinase. This is action is happening in peripheral tissue. This is step number 8. Super high yield concept, very important MCQs and mostly asked questions. Which enzyme causes peripheral tissue conversion, of T4 to T3, that is 5-deiodinase. And this T3 is very, very active. So if there is MCQs, which of the following is active form of thyroid hormone T3? T3. Which of the following is a most abundant thyroid hormone T4? Okay. Now, there is another step here. It is not written here. When there is a T4 converted into T3 in step number 8, T4 is converted into T3. There is also production of reverse T3. This is also a compound called reverse T3. Okay. In 7 and in 8 point, you should also know this. When there is a T4 to 3 conversion, there is also production of reverse T3, or mean reverse. We will study in our next slides what is euthyroid syndrome, and we will have a significance of reverse T3 here. Okay, is that clear? We will study in our next slide. So I revise here. First of all, start from the first blood. Number 1 step here, there is iodine going inside this epithelial cell. And now second step is oxidation of this iodine. Ion is making into iodide molecule I2. Third concept is that when there is the thyroid peroxidase enzyme, it attaching thyroglobulin molecule and attaching the monoiodo and diiodothyronine. And fourth concept is coupling reaction, when mono and di will be attaching one another and making T3, T4. Fifth concept, when endocytosis of T3, T4. And the fourth, fifth, and sixth concept will be a deiodination and recycling of thyroglobulin. Seventh concept is action of proteases and the release of T4, T3 in the blood and circulation. Eighth concept is peripheral conversion of T4 to T3 under influence of 5-deiodinase. And the last concept I discussed, there is that when there is conversion of T4 to T3, there is also a formation of reverse T3. There is a significance in euthyroid syndrome with study next. Now we will go to our theory. Is that clear? The follicle of thyroid 5-deiodinase converts the T4, the major thyroid product, to T3 in peripheral tissue. Is that clear? Next, peripheral conversion is inhibited by glucocorticoids, beta blockers, and propylthiouracil. We will study a medication, of course. You also should know this: a glucocorticoid, beta blocker, propylthiouracil. The last eighth step, we discuss about the peripheral conversion, which happen in peripheral tissue, that is inhibited by glucocorticoid, beta blocker, and propylthiouracil. Propylthiouracil is a drug that used as an antithyroid. Next concept is I have already discussed is reverse T3 is a metabolically inactive byproduct of peripheral conversion of T4, and its production is increased by the growth hormone. Very important concept, and glucocorticoid. So here is the MCQs here. So which of the following increases the peripheral conversion of T4 to T3 and production of reverse T3? Increased growth hormone and glucocorticoid. So this is the relation of euthyroid 6 syndrome. We will study in our next lecture. Actually, the stress, infection, post-surgery, post-surgery. These are the mostly condition, okay, that is causing the increased reverse T3. Infection, stress, post-surgery. So you have seen that when there is a stress, when there is an infection, when there is a post-surgical condition, post-inflammatory condition, there is increased stress hormones. Also, so these stress hormones are growth hormone and glucocorticoid. So in these conditions, why is the logic that there is reverse T3 is increased? The reason is that there is increased growth hormone and increased glucocorticoid in these conditions. And these are the also causes of euthyroid 6 syndrome. We will study in the next euthyroid 6 syndrome. So there is in euthyroid 6 syndrome, there is the increased reverse T3. So there is a generalized concept we will study next in our in next slide. Okay, so function of thyroid peroxidase include, so we have discussed about the enzyme that is causing the organification and the coupling of the monoiodo and diiodo tyrosine, that is thyroid peroxidase enzyme. And next, inhibition is happening by the propylthiouracil and methimazole. Methimazole and propylthiouracil, these are the two drugs that are called anti-thyroid drugs. Anti-thyroid drugs. These are propylthiouracil, ETU, and methimazole. We have already discussed when DIT is making the T4, when DIT is attaching with MIT is making the T3. Next is the Wolff-Jakob effect. So there are two concepts here. One is Wolff-Jakob effect. Next is Jod-Basedow phenomenon. Jod-Basedow phenomenon. We will study detail in the pathology, but I am making a generalized concept for Wolff-Jakob effect and Jod-Basedow phenomenon. These are the two concepts. Wolff-Jakob says that when there is excess iodine, then there is a turning off production of T3, T4. So more iodine will causes the down regulation, decrease T3, T4, and this is protective autoregulatory. This is Wolff-Jakob effect. But Jod-Basedow phenomena says that when there is already deficiency of the iodine, when you give the iodine, there is a more production of T3 and T4. That is Jod-Basedow. We will study in hyperthyroidism what is Jod-Basedow phenomena and what are the different conditions that causes this. So just you should know Wolff-Jakob effect and Jod-Basedow are opposite. These are the opposite. Is that clear? So Wolff-Jakob effect is that effect when there is excess iodine given to already a normal person. Then this excess iodine will temporarily decreases the production of T3 and T4. That is a Wolff-Jakob effect. Opposite of Wolff-Jakob effect is Jod-Basedow phenomenon. What is this? When there is a patient who is already a deficient in iodine deficient patient in hilly areas of, like you can say hilly areas of Pakistan, hilly areas of like Gilgit, in other, there is their iodine deficiency. When you give the iodine to that person, there will excess production of T3, T4, and you will find the more T3, T4 in the blood after giving the iodine. The more T3 after giving T3, 4 after giving the iodine, in already there is must be a reason. So the increased production of T3 T4 after giving this iodine, which is opposite the word step effect, that is jaw vasto phenomenon. More detail we will discuss in the next is function. You should know the salmon bees. Salmon bees. First of all, what is the site of action of thyroid hormone? Site of action is the nuclear receptors. So T3 is very important. So they will ask you which of the following is active nuclear receptor activated, that is T4 or T3. So T3. So remember, nuclear receptor or T3 receptor, which are more and having a greater affinity. So they will ask you which of the following has more affinity, greater response, greater effector molecule response, that is T3 as compared to T4. Which of the following is more active form, T3? Which of the following is highest uh, concentration, highest volume, that is T4, but active is T3. More affinity and nuclear receptor, T3. Is that clear? Next, what are the functions? Salmon bees, brain maturation, bone growth, and this have a synergism. Synergism means same action or augmenting, boosting of the function of the growth hormone. So the growth hormone and T3, T4, they both act synergistically to increase the bone growth. And also beta adrenergic effects. Thyroid hormone, specifically T3, increases beta 1 receptor in the heart and increases the cardiac output, heart rate, stroke volume, contractility. So that's the reason in hyperthyroidism we give the beta blocker to alleviate the symptoms. Super high yield exams question here, MCQs here, super high yield. Why beta blocker given in thyrotoxicosis? The reason is to control beta adrenergic symptom. Next, basal metabolic. Basal metabolic via because T3, T4 act on intracellularly and intracellularly they activate the increase the upregulation of sodium potassium ATPase activity. And sodium potassium ATPase activity increases our basal metabolic rate. So when there is an increased basal metabolic rate, there is overall consumption of oxygen in our body is increased. Respiratory rate is increased and body temperature is increased. Also T3 and T4 increases the glucose in our body, in our blood, plasma glucose increase. And so glycogenolysis mean lysis mean breakdown. Glycogeno means glycogen. So glycogen breakdown happen when there is increased T3, T4. And gluconeogenesis, new production of glucose also happens. The two steps we'll study in biochemistry, glycogenolysis, gluconeogenesis. Okay, so blood sugar is increased. Next, break down the lipids, lipolysis. Lysis is breakdown, lipo means lipid. So it causes the lipo. So weight loss happens when there is excess T3, T4. We will study next page what are the different functions. Next, simulate surfactant synthesis in babies. Very important also. Also, we have discussed surfactant synthesis is augmented by glucocorticoids. So glucocorticoids, thyroid hormone, both increases the surfactant. Regulation. What is regulation? We have already discussed in detail the regulation. That regulation is first start from hypothalamus. Hypothalamus releases thyrotropin releasing hormone. Thyrotropin releasing hormone. This thyrotropin releasing hormone increases the TSH. TSH from anterior pituitary. Okay. Or now this TSH act on the follicular cells. So first step was thyrotropin from hypothalamus. And next step was TSH. TSH was released from anterior pituitary. TSH will go to act on these thyroid follicular cells and they will cause all the steps we have discussed. Next is the thyroid stimulating immunoglobulin may augment the follicular cells to more and more production of T3, T4. That happens in Graves' disease. In Graves' disease, it is because autoimmune disease, so there is thyroid stimulating immunoglobulin. Very important super high yield. Thyroid inhibiting immunoglobulin happen in Hashimoto thyroid. Thyroid stimulating immunoglobulin happen in Graves' disease. We will study in pathology. Okay. So next is what is the negative feedback? Negative feedback is when there is decreased sensitivity in inferior pituitary, decreased sensitivity to the TRH, and hypothalamus when there is decreased sensitivity to the thyrotropin releasing hormone secretions. Next is super high yield exam questions. Super high yield exam questions. This. This is super high yield. What are the conditions that very important increases thyro, thyro, thyroxine binding globulin or thyroglobulin? Thyroxine binding globulin, that is a protein present in our body. So there are some compounds in our body, like the thyroid and other hormones, that are attaching with our proteins that are normally present in our body at a specific regulated rate. Okay, one of them is thyroxine binding globulin. That is basically a protein, TGP, that is normally present in our body. But there are specific conditions that increase or decrease that. So that specific condition alters our T3 and T4 level in blood. Okay. So what are the conditions that increases the thyroxine binding globulin, and what are the conditions that decreases thyroxine binding globulin? First, to understand when there is increased thyroxine binding globulin, what will be effect? First of all, high yield, super high yield exam question. When there is increased thyroxine binding globulin, this happen in pregnancy, oral contraceptive use. What will happen on the free T3, T4, and what will be the change in total T3, T4? Super high yield. They will ask you the arrow question. One, they will give you free T3, T4, and the other side, they will give you total T3, T4. So they gave you the arrow question. So they will give you history. The patient has been taking oral contraceptive pills for the previous 4 years. Now, what will be the change in the T3, T4 in this case? So they will give you free T3, T4. They will give you like this arrow question increase, total T3, T4 increase. They give you a second option that free T3, T3, T4 decrease, total T3, T4 increase. Okay. So they give you another decrease and decrease. So which is the right answer? So we are discussing this when there is increased thyroxine binding globulin. So what will be the right answer in arrow question? So what will be the change in free T3, T4? Okay. What will be the change in total T3, T4? The two different concepts, free T3, T4 and total T3, T4. Okay. So it is already written there, increase total T3 and T4. So of course, this is the wrong answer here. So there must be alpha or beta. Now, what will be the free T3, T4? And there is increased thyroxine binding globulin. When there is increased thyroxine binding globulin, there will be a decrease in T3. Okay? Because the free molecule of T3, T4 will be decreased. Now, more of the T3, T4 will go to bind on thyroxine binding globulin. So free will be decreased. So total T3, T4 will be high. Remember always. Why? Why? I will tell you a logic. Everything in first aid has a logic. The first aid without any logic is nothing. Okay. This first aid is a Bible. Okay, so it has a more than 1 million knowledge. Every word, every concept, every line is a MCQs. Okay, so there is just written, but there is a 5, 6 MCQ. This one line. Now, why this answer is right? Why decrease 3, 3, 3, 4? First, make a concept in your mind. Okay, when there is increased thyroxine binding globulin, there will be a capturing more T3, T4. Let's suppose these are the molecule of the TBGs here. So they will capture here T3, T4. So now let's suppose there were 5 molecules of the T3, T4. But when we add this total, thyroxine binding globulin, so there are not the 5 molecules. Now there are 3 molecules. Okay, there are 3 molecules. Now there are 3 molecules because there is thyroxine binding globulin that is capturing this T3 and T4. So now there were 5 molecules. Now there are 3 molecules here. There is a decreased T3 and T4. So it means there is a free T3, T4 will be decreased. No, but why there is increase total T3, T4? Why there is? Can anybody tell me why there is increase total T3, T4? Free T3, T4 is less, but why total T3, T4 is increased? This is a very important concept to understand. The reason is that there will be due to feedback response. Feedback. What will be feedback? When there is free T3, T4 that are determining our feedback response. And that feedback response will be more TSH. When there is a free T3, T4 will be releasing more TSH. The more TSH will act on these thyroid follicular cells. There will be more production of T3, T4. More production of T3, T4 will causes the more entry of this T3, T4 inside the blood, and more entry because the thyroxine binding globulin are waiting to capture T3, T4. Remember always, they are waiting to capture. So when there is a more T3, T4, the all will be captured again by this thyroxine. So more and more will be attaching with this thyroxine binding globulin. So that's the reason it increases total T3, T4. But the basal level more decrease in free T3, T4. Is that clear? So this is the logic why increase T3, T4 total via the, because the feedback response increased TSH mediated more T3, T4, more T3, T4 will be captured by this thyroxine binding globulin. So free T3, T4 will be high, but sorry, total T3, T4 will be high, but free T3, T4 will be low. This happen in the hyperestrogenic estrogen condition, hyperestrogen condition, pregnancy, oral contraceptives. Okay, okay. So you can see condition that alter these thyroxine globulin, that are the pregnancy, oral contraceptive, and the what is HRT, hormone replacement therapy. Because in hormone replacement therapy we also give estrogen compound, and there is a tamoxifen drug that is also used. That is also the modulator of estrogen. It activates estrogen. Same. And acute hepatitis. Very interesting. Not written in first aid. You can write it down. Acute hepatitis. Acute hepatitis. Next, decrease. Next, we will discuss the decrease high thyroxine binding globulin. So it will be a reverse effect when there is a decrease. So what will happen? Total T3, T4 will be less. Total T3, T4 will be less, and free will be high. Reverse effect. Now we will discuss the causes that decreases this thyroxine binding globulin. And these are the androgenic hormones, not estrogen, androgenic. Why? The reason is that when there is increase androgen hormones, the relatively estrogen-androgen ratio is disturbed. Is that clear? So this disturbance of this ratio will causes the decrease PPGs. And high dose glucocorticoid and hypercortisolism. Okay, so this also, of course, decreases this. And hyperproteinemic condition, hypoproteinemic condition decrease protein, that is seen in nephrotic syndrome and starvation. Nephrotic syndrome and starvation. And the last is chronic liver disease. Chronic liver disease. Very important. Acute hepatitis increases thyroxine binding globulin, but CKD, cirrhosis, that decreases because the liver function is decreased in the CKD. So that's the reason it decreases the production of proteins, so decreases VPG in chronic liver disease. Okay. Now we have discussed this concept about T3, T4. We have discussed the functions. Now we will discuss a few of the more concepts about thyroid. We will discuss about very important concept related to thyroid, that is beta HCG. Actually, we have discussed in our first lecture the alpha subunit and beta subunit. The alpha subunit is same as in the thyroid as in the beta HCG. So when there is pregnancy, okay, when there is conception, there is increased beta HCG. Increased beta HCG, okay. So in the pregnancy, when there is a first 8 weeks, the first 12 weeks, there is increased beta HCG. Increased beta HCG having a same alpha activity as like the thyroid. So what will happen? What will happen? It causes increased T3, T4 production. Remember, so early pregnancy is hyperthyroid condition. Hyperthyroid condition. So early pregnancy is hyperthyroid condition. This is important question they will ask you. A pregnant lady, they will ask you who has just a 3-month pregnant, having a symptom of like fatigue, diarrhea. Okay, they will give you symptom of palpitations, tachycardia, tachypnea, diarrhea. They will muscle weakness, all the other symptom of hyperthyroidism. But they will give you, so which of the following is the cause of this hyperthyroidism in this pregnancy? So you will say this is due to alpha subunit of beta HCG hormone. So increased beta HCG in early pregnancy because of similarity of this alpha subunit, it causes hyperthyroidism. So what will be happening? So what will be lab values? They will ask about the lab values in thyroid hormone in pregnancy, super high yield, extremely super high yield for MRCP, for USMLE Step 1, for USMLE Step 2, for USMLE Step 3, for the PLAB. All exams, most likely in MRCP and USMLE steps, they always ask this question. Okay, thyroid hormone in pregnancy. Thyroid hormone in pregnancy. Okay, so what will be total hormone? Total T4 will be increased because beta HCG stimulates the thyroid hormone that production happens in the first trimester. So what will be free T4? Free T4 will be unchanged or mildly increased. Okay, mildly increased or no change. And TSH, of course, will be decreased because when there is hyperthyroid, the feedback response to the hypothalamus and pituitary will be suppression of TSH. So remember, they will give you arrow question. They will ask about you this total T4, free T4, TSH. So they gave you arrow question. Remember, this is the right arrow question. Total T4, arrow question increase. Free T4, no change or increase. TSH decrease. So this is the right answer. This is the right answer. Okay. Most likely step 2, step 1, they ask like this. Is that clear? Pregnancy, of course, TBG is increased in pregnancy. TBG increase in pregnancy. So when there is increased TBG in pregnancy, there is increased total T4. So some of the students say that pregnancy is increasing total T4, but free T4 is decreased in pregnancy because of the increased TPG. But here you can say there is no change or mildly increased. So I want to highlight here. There is a only first trimester I am discussing. There is early 8 week, 9 week, 10 week, 12 week, just okay. After that, all the response and all the changes because protein production and protein effect takes times. Of course, estrogen stimulates also to production of thyroxine binding globulin. Okay, but thyroid is also having a hyperactivity due to alpha regulation of beta HCG. So beta HCG also increasing the thyroid. So there is a counterbalance. Okay, so at the one end, estrogen stimulates TBGs that decreases free T4. At the other end, the alpha activity of beta HCG increases the hormone production. So they will balance the. So that's the reason sometimes there is no change in free T4. But sometimes the effect of alpha effect of beta HCG hormone is superior as compared to the TBG effect by the estrogen. Is that clear? Is that clear now concept? Okay. Now we will discuss about the euthyroid 6 syndrome. Euthyroid 6 syndrome. Okay, I repeat here. I repeat. There are two concepts in pregnancy. In pregnancy, there in the first trimester. First of all, you should know that there is also pregnancy increasing because it is hyperestrogenic condition. Pregnancy is the hyperestrogenic condition. Okay, increases estrogen, and we have discussed that when there is increased estrogen, there is increased thyroxine binding globulin. And there is increased thyroxine binding globulin, it increases the total T4, total T3, T4, and decreases the free T4, T3. Okay. So, but when there is beta HCG in the first trimester, beta HCG hormone has alpha effect that is stimulating thyroid to produce more T3, T4, more T3, T4. So this pregnancy, the second effect is alpha subunit of the beta HCG hormone. Okay, so what will be happening? So it will increasing the free T4, T3. So this effect will be counterbalanced by this effect. Okay, So this will be no change, unchanged free T4. Both the condition, hyperestrogenic condition and the alpha subunit of beta HCG, both are increasing the total. Total is no issue. Total will always be increased. When there is a total is increased, the feedback response TSH will also be decreased. But the free will be unchanged and a mild increase due to the exaggerated effect of this alpha subunit, but it will be only in first trimester. Second, third, there will be free T4 will be no change, or mildly there will be mildly no change. But increase happen in first trimester due to increased activity of beta. Is that clear? Next is euthyroid syndrome. We have discussed about a basic concept about this euthyroid. Actually, it is a condition due to when there are some illness, stress, infection, some inflammation, post-surgical patients, some using of the cytokines, some of using of the drugs like immunoderone, some of the uh, condition that is starvation, some of the eating disorders. These all are the condition that causing euthyroid syndrome. Okay. So what are the etiology of euthyroid syndrome? Etiology of euthyroid syndrome is stress condition. Generalized concept, I will say, first of all, understand the stress condition. Stress, okay, surgery, infection, okay, these are the causes. Increased inflammation, okay, and there is the eating disorder, okay, there is starvation, and there is the immunoderone use, drug of immunoderone that causes euthyroid syndrome, and also there is the hypercortisolism, increased cortisol, and also there is the cytokines, increased cytokines release. So these are all the condition that causes the euthyroid syndrome. So what are the basic concept here? The basic concept here is that these all condition inhibits the conversion of T4 into T3. Super high yield important concept. The reason is that the T4 to T3 and reverse T3. I have told you these are the two pathway here, but this is inhibited. The peripheral conversion is inhibited. T4 is not converted into T3. Now, when there is no conversion of T4, T3 in peripheral tissue, so what will be happening? All the T4 will be converted into reverse T3, and the increased production of reverse T3 happens. Okay, so when there is euthyroid syndrome in early period, what will happen? There will be decreased T3 because there is decreased conversion. T4 will be normal because in mild cases there is normal feedback. In mild cases there is normal feedback, and normal feedback increases the T4. So normal feedback increases the TSH, and TSH causes more production of T3, T4. Sorry, more production of first T4 first made, and after this T4 it will be normalized. Because T4 is normalized, so there will be also TSH will be normal. But reverse T3 will be high. I have told you because T4 is not converting into T3, so reverse T3 will be high. So super high yield in early or mild cases, the T3 always will be less in either it is early condition or severe condition. And reverse T3 will be high always. So remember these two very important. T3 is low, reverse T3 is high. Whenever these conditions seen, always consider euthyroid syndrome. Reverse T3 is high and normal T3 is low. Always either it is mild condition, either it is severe condition. But normal T4, normal TSH in mild condition, decrease T4 and decrease TSH in the prolonged and severe condition. Is that clear? Now we will go to discuss this about this theory, what is written here. The patient with low T3, okay, normal T4, normal TSH in setting of acute illness like ulcerative colitis treated with glucocorticoid. They will give you scenario, any scenario, like there was the ulcerative colitis and we have given the glucocorticoids. There was the other condition, dermatomyositis, we have given the glucocorticoids, and that excessive use of glucocorticoid causes these changes in the labs. So what will be the reason? So you should know all of the etiologies I have told you: infection, surgery, stress, cytokines, mutterone, cortisols, whatever the condition. So what happens? They decrease conversion of T4 to T3. And these factors that inhibit this peripheral deiodination includes the cortisol level, inflammatory cytokine like tumor necrosis factor alpha, some starvation and medication, glucocorticoid and mutterone. We have discussed it already. TSH and T4 may often normal, although they also fall in rare or prolonged cases. We have discussed about this. And response as a, because sometimes euthyroid may represent a transient central hypothyroidism. Super high yield question. When there is a prolonged severe disease, so it acts as a central hypothyroidism. Central hypothyroidism. Central mean there will also be decreased TSH. So all of you people should have asked to be, okay, when there is a decreased T3, when there is decreased T4, why there is decreased TSH? It must be increased TSH. But no one asked this question. Okay, the reason is that actually this prolonged condition of infection, stress, thyroid, glucose, all this causes central hypothyroidism. The problem in the central level, in hypothalamus level, they actually starts to decrease the TSH. And euthyroid now becomes the central problem. Is that clear? So what is the treatment? Remove the inciting problem. Okay, remove the inciting problem, remove the illness, remove the cause. Is that clear?